Okay, this is chapter 58 on stroke. I just wanted to go over a few things before we start into the stroke chapter. Ischemia is the inadequate blood flow. Hemorrhage is bleeding. There is a box on page 1389, 58-1 that goes over the warning signs of a stroke. This is always, I think, something that is very important to educate all patients on so that they would know what to do or the signs and symptoms, because when it comes to a stroke, timing is very crucial. It also depends on what type of stroke the person has had. Blood is supplied to two major arteries, the internal carotid and the vertebral. Brain requires continuous blood supply and provides O2 and glucose to the neurons that need to function. So we actually protect our brain. Our brain is one of those core organs that we protect and do everything we can protect. There's the blood-brain barrier that protects it from anything going into the brain and harming it. Areas of the brain can receive blood from another area when cut off. So an example of this would be if you do have a thrombosis, that supply is cut off, blood supply is cut off to that area. So blood from other areas will try to provide or perfuse blood to protect the brain. It's a protective mechanism. If you have increased intracranial pressure, which you'll also see it written as ICP, compression is reduced with cerebral blood flow. The major goal of a stroke is to reduce secondary injury related to increasing cranial pressure, because intracranial pressure is a risk or complication of a stroke. So when we talk about stroke, we have to talk about non-modifiable risk factors and modifiable risk factors. A few non-modifiable risk factors are age, gender, race, hereditary. Modifiable, and the number one modifiable risk factor is hypertension. Heart disease, diabetes, smoking. Excessive alcohol is a modifiable risk factor. According to your textbook, I want to say that there is a normal daily dose that is acceptable that does not meet the definition of excessive. And I want to say your textbook says for men it's 2 drinks per day, for women it's 1. So it'd be like 1 glass of wine, and I'm not talking like that super duper 32 ounce size. It's usually about a 4 to 6 ounce pour. Obesity, sleep apnea, and drug abuse are also modifiable risk factors. So when we talk about a TIA, or transient ischemic attack, this is caused by focal, spinal cord, or retinal ischemia. It's a microemboli that's temporarily blocks blood flow without acute infarction of the brain. So these are mild, or maybe you'll hear someone call it a mini stroke. Symptoms last less than 1 hour, but it also depends on the blood vessel that is involved. So you can have the carotid system involvement, and this is temporary loss of vision in one eye. You can have hemiparesis, and I'm going to put that here. So we're talking right now about the carotid system when we're talking about a TIA. You have numbness or loss of sensation and a sudden inability to speak. You can also have involvement in the vertebral basilar system. These symptoms would be tinnitus, vertigo, darkened or blurry vision, diplopia, ptosis, dysarthria, dysphagia, and when I'm talking about dysphagia, I'm talking about dysphagia spelled with a P, H. Ataxia, unilateral or bilateral numbness, or weakness. And this is for the, if I can squeeze it up here, vertebral basilar system that we're talking about. So we have two systems, carotid and vertebral basilar systems when we're talking about TIAs. So the signs and symptoms would vary depending on where the mini stroke actually is. So now we're going to talk about the different types of strokes. You can have an ischemic stroke, and then an ischemic stroke is actually broken down even further into two categories, thrombolytic and embolotic stroke, and then you can have hemorrhagic strokes. So when we're talking about ischemic strokes itself, this is inadequate blood flow to the brain from the partial or complete occlusion of an artery. If it is a thrombotic, injury to a blood vessel wall and formation of a blood clot appears. It develops where atherosclerotic plaques have narrowed the blood vessels and may progress in the first 72 hours as an infarct, and then you have cerebral edema that will actually increase. So we're talking about the first picture here where you have the plaque, which you see on the sides, and then you have the clot formation that forms and it cuts off that blood supply to the brain or in that artery. If we have an embolotic stroke, ischemic stroke, an embolus lodges in or occludes a cerebral artery. Most of them start in the endocardial layer of the heart, which is the inside layer. People who are at risk for embolotic strokes are people who have AFib, have had MIs in the past, endocarditis, rheumatic heart disease, valvular issues, and atrial septal defects. Symptoms occur suddenly, and most of the time the patients will complain of a headache. When we talk about hemorrhagic strokes, this is actual rupture of the vessel. They do not have a good prognosis. As you think of hemorrhagic, you think bleeding, hemorrhage, profuse, immediate. Hypertension is usually the common cause of a hemorrhagic stroke. It occurs during periods of activity. It is a sudden onset with progression over minutes to hours. They may complain of headache, nausea, and vomiting. We need to monitor neurostatus. We need to also monitor if there is improvement or deterioration of increased cranial pressure. We need to control the blood pressure. This is actually critical when it comes to a hemorrhagic stroke. We cannot allow the blood pressure to drop suddenly, because what's happening is our blood pressure is acting as a protective mechanism for our brain and our body. So if we drop that too quickly, we put the patient at a risk of another stroke. So that is critical in the first 24-hour period to make sure that that blood pressure is decreased slowly. Remember, we talked about in cardiac where they'll put special lines in to measure the blood pressure and obtain a number, and the number that they're going to look at is the MAP. That this is possibly one of those areas that may happen also. The other thing is the patient may get TPA. Neurovascular specialists can put interarterial TPA in, but a nurse can administer IV TPA. Usually the patients will have ordered an aspirin within 24 to 48 hours after the onset of the actual stroke itself.